So this is the second part of endocrine. So first I want to talk about the pituitary gland because I feel like many of the bodily functions, including what we're going to talk about, stems from the pituitary gland. So if you see, which I'm sure you've done your readings already, that it is a pea-sized gland that's in the brain, very tiny. And there's a pituitary, there's an anterior, and there's a posterior and pituitary gland, which above that is the hypothalamus. So first let's talk about what the pituitary gland is responsible for. So there's the posterior and anterior. The posterior gland is responsible, it doesn't produce hormones, but rather stores and secretes hormones produced by the hypothalamus. So for example, oxytocin, vasopressin, antidiuretic hormone. And when we talk about the anterior pituitary gland, we have all these hormones here. So TSH is your thyroid, which I won't write all these out actually. Your ACTH hormone, the adrenocorticotropic hormone, that is stimulates the hormone released by the adrenal cortex. So that's above, remember they sit above your kidneys. The luteinizing hormone stimulates androgen production by the gonads, and follicle stimulating hormone stimulates the gamete production in gonads. The growth hormone promotes growth in body tissues. And then we have prolactin that promotes milk production for mammary glands. So you can see that there's a lot of working machines going on. And so if there's an issue with the pituitary gland, for example, if it starts to overfunction, then why is it overfunctioning? So it can overstimulate or overfunction, most commonly because you have a tumor growth in here, because think it's not going to then function properly. And so you're going to have one or a few of these hormones being affected, including, depending on where it's at, if it's in the anterior or posterior. So most commonly is an adenoma. So if there's any dysfunction in these, it will present itself as symptoms, signs and symptoms. So, but you have to go according to what hormone is dysfunctioning. So for example, if your ACTH is that's secreted from the pituitary gland, if it's being excreted in excessive amounts or too much, you have to go back. Where is this coming from? Is it coming from the adrenal hormones? Because remember, ACTH is stimulates. It's a peptide that stimulates the hormone released by the adrenal cortex. So then you'll start having symptoms such as weight gain. Think of Cushing's disease, water retention, that moon face, and the hump on the back, abdominal striae. So then that is where you'll have issues with that. So I'll talk about the growth hormone. Growth hormones, remember, are released into the bloodstream by the pituitary gland, the anterior pituitary. And what would happen if there's excessive exposure or excessive release of the growth hormone? Well, there's acromegaly or gigantism. So important things to remember is gigantism is in children and acromegaly is in adults. And it has to do with the growth plate cartilage versus the epiphyseal growth plates that are open during childhood. So children are gigantism and adults acromegaly when there's a oversecretion of the growth hormone. So now we'll talk about Cushing's and Addison's. First of all, we'll talk about Cushing's, which is an overproduction of cortisol. So remember, when it's stimulated, stimulated by ACTH, the adrenal gland secretes cortisol and other steroid hormones, but ACTH is produced by the pituitary gland, and it's released in response to stimulation from the corticotropin releasing hormone from the hypothalamus. So in that case, what happens is your adrenal glands start secreting too much cortisol. And as you can see in the pictures here, this is a glucocorticoid excess. So patients that are on long-term steroids are at high risk, and actually one of the most common reasons for Cushing's disease. And you can see that they get the moon face, the abdominal striae. They can also get a hump on the back. They have edema, they have elevated blood sugar, and weight gain. Just to go down here, though, what do steroids do? Well, when we think about steroids, we think about cortisol. So when you take exogenous cortisol, it'll be hydrocortisone, cytomedrol, prednisone. There's different terminology or different brand names versus generic names of medications. But cortisol is excreted by the adrenal gland, but it has a lot of functions in the body. For example, in the bone, it reduces the bone formation, promotes breakdown of fat. Cortisol counteracts the insulin and decreases amino acid uptake by the muscle and glucose generation in the liver. So as you can see, there's a fine balance with cortisol levels. We don't want it to be too much or too little. It's like this for all of the hormones that are produced in the body. So with Cushing's disease, also they have a decreased immune system. So remember that. Now, if you have not enough secretion of cortisol from your adrenal glands, you can be diagnosed with what's called Addison's disease, where your body's really unable to make cortisol. And with that, you have to have lifetime cortisol replacement, because remember, cortisol is responsible for all of these things in the body, and if you're not able to make it, then it's life-threatening. Patients with Addison's disease have more of an opposite effect versus the the Cushing's disease. So the Addison's disease, you actually have weakness, low blood sugar, you're hypoglycemic, you have hypotension, and you can have bronzing of the skin color. So just to reiterate, with Cushing's disease, you will have increased blood sugar, weight gain, you can be tachycardic, you have the buffalo hump, so think that and hypertension, because you have excess cortisol. Addison's disease, therefore, is the opposite. You're going to have weight loss and low blood pressure, low blood sugar, bradycardia. Okay, so now we're going to talk about the thyroid. So the thyroid, remember, is in the neck area, and you can either have a hypofunction of the thyroid or hyperfunction. But then broken down from there, there's primary, secondary, and tertiary disorders. So primary actually is a problem with the thyroid gland itself, whereas a secondary disorder, it's coming from the place where the messages are being sent. So the anterior pituitary gland, there's something wrong, such as an adenoma, that's not able to send messages properly to the thyroid. And then the tertiary disorder would then be above that, who's talking to the anterior pituitary, then talking to the thyroid. That would be a tertiary disorder because there's a problem in the hypothalamus. So some of the types of hypothyroidism are acquired hypothyroidism, where your body just decides that your thyroid's not going to function as well. This is where the gland just... There's also Hashimoto's thyroiditis, which is the most common cause of hypothyroidism in the United States. So what happens with Hashimoto's thyroiditis is the antibodies attack the thyroid and end up destroying the gland, whereas on the other hand, Graves' disease is the most common cause of hyperthyroidism in the United States. So antibodies attack the thyroid and then turn on itself. So when you think about Hashimoto's thyroiditis, think about your body forms autoantibodies to the thyroid gland. So what happens is these antibodies end up causing inflammation and then end up destroying the gland. So symptoms of hypothyroidism, remember, you're sluggish, you have weight gain, you have a cold intolerance, you're always feeling cold. So make sure you look up the signs and symptoms. There's a whole list of them. Versus hyperthyroidism is the opposite. Tachycardia instead of bradycardia, heat intolerance. A lot of these people end up losing weight. People with hypothyroid are very tired versus hyperthyroid are very have a lot of insomnia and have trouble sleeping. Heart palpitations is a very common symptom of hyperthyroidism. So how do we treat these? So with Graves' disease, we actually have to, there's a couple of different things. There's medications called methimazole or tapazole, which ends up suppressing the thyroid, the hyperfunction of it. Or you can do the radioactive iodine, which is actually the gold standard or the most common treatment for it. Put the radiation in the thyroid, which destroys the thyroid, and then we wait for the thyroid to stop functioning, and then they go on thyroid replacement for the rest of their life. You can do surgical removal of the thyroid, although that would only be if the other treatments did not work, because if your thyroid is hyperfunctioning and you remove it, there could be a chance that you can have some cells grow back. So hyperthyroid is treated differently. So that's how hyperthyroid's treated. Low thyroid is treated with medications. So you'd give exogenous thyroid hormone, which would come in the form of Synthroid or levothyroxine. Okay, so I do want to go over what we're going to see, though, with hypothyroidism versus hyperthyroidism on lab values. So, for example, we have the thyroid stimulating hormone that's coming from the anterior pituitary gland. And then you have your thyroid that makes T4 and T3. All right, so I'm going to put T4 and T3. And this is in your brain, the anterior pituitary. So let's just say that your thyroid is not functioning. So if it's not going to function, your T4 and T3 are going to go down because it's not going to function. So then your thyroid stimulating hormone's going to say, wake up, wake up. And so how does it try to wake it up? It starts excreting more TSH. So your TSH goes up. So whenever you see a TSH that's high and a T4 and T3 that is low, that is a hypothyroid. But let's think the opposite. Now, if your TSH, let's say your T4 is your thyroid, T4 and T3 are going to be elevated if it's hyperfunctioning. So if you have some of Graves' disease, which is antibodies attack the thyroid and actually just like turn on itself, then that's going to be elevated. So your thyroid stimulating hormone in your anterior pituitary is going to say, oh, there's already enough thyroid hormone in there, so we can just slow down. And so your TSH is going to be low in hyperthyroidism. So one more scenario I just want to talk about. Remember the secondary, which is from the anterior pituitary gland. Let's say you have a T4 and a T3 that are normal. So your thyroid is functioning normal, but yet you have a TSH perhaps that's high. Maybe it looks like your thyroid's functioning normal, although sometimes it can be more what's called a subclinical hypothyroidism. But many times it could also mean a pituitary adenoma because what's going on here that's dysfunctioning. It looks like your thyroid's functioning okay, but it's not functioning very well here.